This is an extremely high-yield review video for anyone preparing for the USMLE Step 2 CK and the USMLE Step 3. This video will focus on the GI system, which is a huge part of the USMLE exams. So if you want to increase your score on exam day, then watch this video until the end. What is the most likely diagnosis in a 2-year-old with painless hematochezia and a positive technetium-99 scan? Meckel's diverticulum. Where does technetium-99 concentrate in patients with Meckel's diverticulum? The parietal cells of the diverticulum and stomach. What is the treatment of choice of a pregnant patient who is incidentally found to have gallstones and is asymptomatic? No treatment is needed because most pregnancy-related gallstones resolve spontaneously within 2 months of delivery. What is the treatment of choice of a pregnant patient with symptoms of recurrent biliary colic or acute cholecystitis? Cholecystectomy. So it's very important that you take a closer look at how these patients present. In the previous question, we had a pregnant patient and their gallstones were incidentally found and they had absolutely no symptoms, so no treatment was needed. However, in this question, the patient has symptoms of recurrent biliary colic or acute cholecystitis. So the treatment or the management of these patients change based on their presentation. Very high yield to know this. What is the treatment of choice of an anal abscess? Incision and drainage. Antibiotics are also needed if the patient has diabetes, immunosuppression, extensive cellulitis, or valvular heart disease. Patients with anal abscesses are at greatest risk of developing which condition? A fistula. Which organism can cause profuse water diarrhea due to germination of spores? C. difficile. So recall that this organism is spore-forming, gram-positive, and an anaerobic bacterial. It releases exotoxins A and B, and it is transmitted through the fecal-oral route. Injury to the vagus nerve during gastric surgery can result in which condition? Gastroparesis. What is the next best step in a patient that swallowed a fishbone and experiences odynophagia? A flexible endoscopy. What is first-line treatment for GERD in an infant with appropriate weight gain? Reassurance and lifestyle modification. So this can include upright positioning after feeds, burping during feeds, frequent small volume feeds. It's important to note that GER has peak symptoms at 4 months and self-resolves by age 12 to 18 months. H2 receptor antagonists like famotidine are indicated in patients with GERD who have poor weight gain, irritable despite lifestyle modifications, or a trial of a diet free of cow's milk. So again, it's important to look at the symptoms or the clinical findings of these patients. So if there's an infant with appropriate weight gain, we just need reassurance and lifestyle modification. But if their weight gain is not appropriate, then you may have to consider giving H2 receptor antagonists. What is the diagnostic test of choice of pyloric stenosis? Abdominal ultrasound. What is the most likely diagnosis in a patient that has periumbilical abdominal pain and diarrhea each time they eat ice cream but have no symptoms when they eat cheese? Lactose intolerance. So this is pretty straightforward, but examiners like to mention different dairy products where their patient may have symptoms when they consume ice cream but none with cheese. And it's just their way of trying to confuse you and to choose another answer. But basically, cheese and live culture yogurt have less lactose content and tend to cause few or no symptoms. It's also important to recall that celiac disease can also present with GI distress. However, they also present with growth failure and weight loss. A hemodynamically stable elderly patient presents with painless blood per rectum after IV fluids, type and cross match. What is the next best step in management? Colonoscopy. Recall that diverticulosis patients present with painless hematochezia in an elderly patient. However, for diverticulitis, they have left lower quadrant pain, fever, no blood per rectum, and a colonoscopy is contraindicated due to a risk of perforation. Is the bun to creatinine ratio greater than 20:1 in upper GI bleeds? Yes. However, in lower GI bleeds, it is normal. So that's an important fact to remember. Bun to creatinine ratio greater than 20:1, think upper GI bleed. If it's a normal ratio, think lower GI bleed. What is the underlying cause of indirect inguinal hernia? Failed obliteration of processus vaginalis. What are the two most common causes of blood-streaked stools in a well-appearing infant less than 6 months old? Anal fissures or non-IgE mediated food protein induced allergic proctocolitis. It's also important to note that the latter condition is most common at age 1 to 4 weeks. What is the next best step in a breastfed infant who has FPIAP? Recall that FPIAP is the condition that we just talked about, food protein induced allergic proctocolitis. The next best step is to eliminate common triggers from the maternal diet, for example, dairy and soy. Soy-based formula is not recommended due to the potential cross-reactivity between cow's milk and soy protein. What is the next best step in a formula-fed infant who has FPIAP? Hypoallergenic formula or hydrolyzed formula. What is the prognosis for patients with FPIAP? Tolerance of offending protein by age 1. So typically for these patients, their symptoms resolve within 2 weeks of dietary elimination of the food allergen. If ultrasound findings are absent or inconclusive for acute cholecystitis, what is the next best step? HIDA scan. Which condition causes isolated gastric varices and left-sided portal hypertension and congestive splenomegaly? Splenic vein thrombosis. If a patient presents with clinical features of acute pancreatitis, what is the best next step in establishing this diagnosis? Serum blood tests only. It's important to note that 2 of the 3 are required to diagnose acute pancreatitis. The first being acute onset of persistent severe epigastric pain. Second, elevation of serum lipase or amylase greater than 3 times the upper limit of normal. Of course, lipase is more specific. And third, characteristic findings of pancreatitis on abnormal imaging, which can be contrast-enhanced CT scan or MRI. What is the next best step in management in a patient that does drink alcohol with clinical features of acute pancreatitis, elevated lipase, and normal abdominal ultrasound? Lipid panel. So if alcohol or gallstones isn't the cause of acute pancreatitis, then you need to evaluate for hypertriglyceridemia with a serum lipid panel. What is the most likely diagnosis in a patient who is being treated for acute pancreatitis, then they develop fever, leukocytosis, hypotension, and right upper quadrant abdominal pain? Infected pancreatic necrosis. So to diagnose this condition, you need to do an abdominal CT scan with contrast. And for treatment, you can give meropenem or fluoroquinolone and metronidazole. What is the standard composition of enteral feeding of calorie per kilogram per day and gram per kilogram per day in a patient with adequate baseline nutrition? 30 calories per kilogram per day and 1 gram per kilogram per day for protein. Lower calorie enteral feeds can also be considered for patients with severe malnutrition in order to prevent refeeding syndrome. What is the best diagnostic test in a patient with rapid onset periumbilical pain, benign exam findings, anion gap metabolic acidosis, and a recent MI. Abdominal CT angiography, because we're thinking that this patient may have acute mesenteric ischemia. Which artery is most commonly occluded in AMI or acute mesenteric ischemia? The superior mesenteric artery. Which antihypertensives can cause pancreatitis? Thiazides such as hydrochlorothiazide and most loop diuretics such as furosemide. What is the underlying cause of eosinophilic esophagitis? Chronic Th2 mediated inflammatory response triggered by food antigen exposure. What is the treatment of choice of eosinophilic esophagitis? First-line treatment is elimination diet of the triggers, PPI, and also topical glucocorticoids, for example, fluticasone, sprayed and swallowed. What is the first step in management of infectious gastroenteritis? Rehydration. So typically, if the patient has non-bloody diarrhea, consider a viral cause. But if they do have bloody diarrhea, then consider a bacterial cause. What vitamin deficiencies may be seen in small intestinal bacterial overgrowth? Well, these patients typically present with bloating, flatulence, chronic watery diarrhea, and possible signs and features of malabsorption. They have a low vitamin B12 due to bacterial consumption and high folate due to bacterial synthesis. What diagnostic tests can diagnose SIBO, or small intestinal bacterial overgrowth? Carbohydrate breath testing, endoscopy with jejunal aspirate or culture. What is the treatment of choice of SIBO? Oral antibiotics, for example, rifaximin, ciprofloxacin, and doxycycline. What are risk factors for SIBO? Anatomic abnormalities such as strictures after surgery, motility disorders due to diabetes or scleroderma, immunodeficiency due to IgA deficiency, chronic pancreatitis, or gastric hypochlorhydria. What would CT scan reveal in a patient with colonic ischemia? Colonic wall thickening and fat stranding. What is the first step in evaluation and management of chronic diarrhea? A comprehensive history. In addition to a comprehensive test and routine lab tests, what other tests should be done to investigate the cause of chronic diarrhea? Well, that should be in addition to a comprehensive history and routine lab tests. Stool for microscopy, electrolytes, and fat content. So chronic diarrhea is loose stool with or without increased frequency for greater than 4 weeks. What type of anemia is most commonly seen in celiac disease? Microcytic anemia. Is the stool osmotic gap high or low in celiac disease? High. Recall that patients with celiac disease present with greasy, large volume diarrhea and weight loss, as well as osmotic diarrhea. What will GI endoscopy with biopsy reveal in a patient with celiac disease? Villus atrophy, loss of normal villus architecture, increased intraepithelial lymphocytes, crypt hyperplasia. What is the most likely diagnosis in a patient with a history of GERD who presents with dysphagia to solids and no alarm symptoms? Esophageal strictures. How do you manage a patient with celiac disease? A gluten-free diet. Treat any nutritional deficiencies present. Bone loss prevention. Pneumococcal vaccine. And also give dapsone if dermatitis herpetiformis is present. So some nutritional deficiencies that patients with celiac disease can have include deficiencies of iron, calcium, vitamin D, folic acid, and thiamine. For bone loss prevention, you can obtain a DEXA scan at diagnosis of celiac disease, then repeat the DEXA scan 1 year later if osteopenia was present. What is the most likely diagnosis in a patient with cirrhosis, mental status changes, and diffuse abdominal pain? Spontaneous bacterial peritonitis. Extremely high yield to know this. How would the following be affected in a patient with SBP or spontaneous bacterial peritonitis? So the PMNs would be greater than 250, protein less than 1 gram, SAAG greater than 1.1. What is the next best step in management of a patient diagnosed with SBP? IV antibiotics and albumin. So IV albumin is given to decrease the incidence of renal failure and reduce mortality in patients with SBP. Empiric antibiotics are also given, most commonly third-generation cephalosporins. Also, fluoroquinolones can be given for prophylaxis of SBP. So I had like 3 different slides on this because this topic is extremely high yield, especially for your surgery shelf. You can be seen in your internal medicine shelf and of course on the USMLE exam as well. What is the most likely diagnosis in a 62-year-old with occult GI bleeding and small cherry red lesions seen on colonoscopy. Angiodysplasia. Angiodysplasia bleeding rates are higher in patients with which condition or conditions? End-stage renal disease, aortic stenosis, and von Willebrand's disease. Why can insulin be used to treat elevated triglyceride levels associated pancreatitis? Well, insulin can be used because it activates lipoprotein lipase, which increases the movement of triglycerides out of the plasma, thus preventing further pancreatic damage. So, if patients have a severe form of this condition, such as fever, tachycardia, leukocytosis, lactic acidosis, or hypercalcemia, you can do apheresis. It's also important that you provide supportive measures such as IV fluids, pain control, and antiemetics. You can also give fibrates such as fenofibrates or gemfibrozil to prevent recurrence. What is the most commonly used calculation to predict 90-day mortality in patients with liver disease? Model for end-stage liver disease or MELD. What values are used to calculate the MELD score? Serum bilirubin, INR, serum creatinine, sodium. So the MELD score has largely replaced the Child-Pugh score, which predicted 1 to 2 year mortality. But it's very important that you take a closer look at these different criteria, because you can see a clinical scenario where a patient has liver disease and they ask you which value would indicate the mortality for this patient or predicts outcome for this patient with liver disease. And they can list different lab findings. So it's very important that you know that you're looking out for the serum bilirubin, INR, serum creatinine, and sodium. What is the most likely complication in a patient who is hospitalized due to a varicose bleed? Spontaneous bacterial peritonitis. So to manage these patients, you can give prophylaxis, which is IV ceftriaxone for 7 days, then transition to TMP SMX or an oral fluoroquinolone if patient is ready for discharge prior to the completion of the intravenous antibiotic course. So like I said, we need to give 7 days of IV ceftriaxone. However, let's say that they are ready for discharge on the 4th day of IV ceftriaxone. In that case, you can switch to oral fluoroquinolone so that they can complete their antibiotic course. What is the most common cause of ascites in the United States? Hepatic cirrhosis. How do you calculate the SAAG gradient? Serum albumin minus the acetic fluid albumin. It's very important that you know for the gradient we are subtracting and we are not dividing. So serum albumin minus the ascitic fluid albumin. SAAG greater than 1.1 indicates what condition? Portal hypertension. What conditions are associated with SAAG greater than 1.1? Congestive heart failure, cirrhosis, alcoholic hepatitis. What conditions are associated with SAAG less than 1.1? Peritoneal carcinomatosis, peritoneal tuberculosis, nephrotic syndrome, pancreatitis, serositis. So it's very important that you can name or think of these conditions when you see or you have to calculate an SAAG. So if it's less than 1.1, think of these conditions listed on the screen. However, if it's greater than 1.1, you want to think of CHF, cirrhosis, and alcoholic hepatitis. What tests can be done after 4 weeks of treatment to confirm H. pylori eradication? Urea breath or fecal antigen testing. It's important to note that H. pylori serology tests evaluate the presence of antibodies, which can be present after the eradication of H. pylori. So, to evaluate or confirm H. pylori eradication, we would want to avoid H. pylori serology tests and instead do urea breath or fecal antigen testing. What drugs are most commonly used in triple therapy for H. pylori? Omeprazole, clarithromycin, and amoxicillin. True or false? Breastfed infants have decreased stool frequency after the first month of life. True. What electrolytes imbalances facilitate hepatic encephalopathy precipitation? Hypovolemia, hypokalemia, and metabolic alkalosis. So hypovolemia is one of the most common precipitants of hepatic encephalopathy. And for hypokalemia, what this does is facilitate the conversion of ammonium to ammonia. And what the metabolic alkalosis does is decrease the urinary loss of ammonia. So basically, the hypokalemia and the metabolic alkalosis, they really increase the ammonia levels. So it's important to remember this fact that elevated ammonia can lead to hepatic encephalopathy. How often is colonoscopy recommended for patients with FAP who have not undergone prophylactic colectomy? Annual colonoscopy. Patients with greater than 20 millimeters polyps that are removed piecemeal should undergo a second look colonoscopy within how many months? 6 months. 5 to 10 adenomatous polyps less than 10 millimeters, tubular adenomas greater than 10 millimeters, villus or tubulovillus histology, high-grade dysplasia, require repeat colonoscopy in how many years? So basically this question is asking if you see any of these conditions, how often do you have to repeat colonoscopy? 3 years. If there are greater than 10 adenomas, how often will colonoscopy need to be repeated? So if you would like me to create a video on the high yield USPTF guidelines, just to prepare for your USMLE exams or your shelf exams, let me know in the comment section below. But to continue preparing for your exams, all you have to do is click this video right here. What are the stimulant drugs used to treat ADHD? Methylphenidates, amphetamines. So how I remember it is that if the drugs have pH in it, then they are stimulants. But if they don't have pH in it, like clonidine, then they are non-stimulants. What is the treatment of choice of leptospirosis? Doxycycline. Recall that this medication is also used to treat Lyme disease if the patient is greater than 8 years old. If they are less than 8 years old, then we use amoxicillin. Doxycycline can also be used to treat Rocky Mountain spotted fever. What are the drugs of choice for endometritis? So this can be remembered with the mnemonic ECG. Endometritis is treated with clindamycin and gentamicin. ECG, clindamycin and gentamicin. Which antitussive is a coding analog and may cause serotonin syndrome? Dextromethorphan. What drugs can cause digitalis toxicity if they are used together? Amiodarone, verapamil, quinidine. So acute toxicity with digitalis can present with GI symptoms such as anorexia, nausea, vomiting, abdominal pain, while chronic symptoms present with neurological symptoms such as blindness, weakness, and scotomas. What diuretic can worsen or cause gout? Loop diuretics. What drug is a mucolytic and an antidote for acetaminophen overdose? N-acetylcysteine. What condition can present after 6 days of phenylephrine use? Rebound congestion. Recall that phenylephrine and pseudoephedrine are alpha agonists that are used as nasal decongestants. However, when you use these medications, it can result in hypertension and CNS stimulation and anxiety. What drugs can cause agranulocytosis? Well, you can remember this as AC. So antithyroid medications, clozapine, carbamazepine, chloramphenicol. So you can remember with this image right here of the 3 air conditioners. Also recall that chloramphenicol can cause gray baby syndrome. Which drugs can cause photosensitivity? sulfonamides, amiodarone, and tetracyclines. You can remember this by saying I sat for a photo. What is the first-line treatment for bulimia? Fluoxetine, which is a SSRI. What are 3 herbal supplements that can increase the risk of bleeding? Garlic, ginseng, and ginkgo biloba. Probably pronounced those incorrectly, but let's look at the spelling here on the screen. Which antidiabetic should be held before doing a CT with contrast? Metformin. Recall that metformin is a biguanide, and one of its very famous adverse side effects is that it can lead to lactic acidosis. So because of this risk of lactic acidosis in patients with metformin, the contrast can further potentiate this lactic acidosis, making it very dangerous for patients. So what is recommended is that metformin is withheld from the patient before doing an imaging test that requires contrast. Which drug can be used in the management of chronic myeloid leukemia? Imatinib. What is an antidote for this substance? Fresh frozen plasma, vitamin K. What is the drug of choice for leishmaniasis? Sodium stibogluconate or amphotericin B. Recall that this condition is transmitted by sandflies. What drugs can cause pulmonary fibrosis? Busulfan, bleomycin, amiodarone, methotrexate. I'm sure that you can list other drugs that cause pulmonary fibrosis. Please list them in the comment section below. What is the treatment of choice of pertussis? A macrolide. So this is also used for prophylaxis for close contacts as well. What drugs can cause drug-induced Parkinsonism? Dopamine receptor antagonists. And of course, metoclopramide has some dopamine blocking effects as well. And it's important to note that these drugs can also lead to neuroleptic malignant syndrome. What is first-line treatment for trigeminal neuralgia? Carbamazepine. It inhibits neuronal high-frequency firing by reducing the ability of sodium channels to recover from inactivation. So it's very important that I mention the mechanism of action here because this question is so common on exams and on the USMLE. So instead of just listing carbamazepine, they've started to list the mechanism of action of the drug instead. So just take a closer look at this and commit this to memory. What antihypertensive agents are safe to be used during pregnancy? Hydralazine, labetalol, alpha-methyl-dopa. And a lot of people remember this by saying hypertensive moms love nifedipine. Hypertensive for hydralazine, moms for methyl-dopa, love for labetalol, and N for nifedipine. Hypertensive moms love nifedipine. Very high yield to note this. What are signs of phenytoin toxicity? Nystagmus and gait unsteadiness. What anti-anginal agent is used to treat chronic exertional angina refractory to conventional medical therapy? Ranolazine. How do you manage someone with HIT or heparin-induced thrombocytopenia? Stop heparin, then administer direct thrombin inhibitor. What is the treatment of choice of pyelonephritis? Ceftriaxone. Which anti-diabetic drugs increase the risk of UTIs? The anti-diabetic drugs with flo in it. So dapagliflozin, empagliflozin. What is the first-line treatment for malignant hyperthermia? Dantrolene. This blocks the receptors and prevents the release of calcium into the cytoplasm of skeletal muscle fibers. What possible side effect can result from using statins and fibrates? For example, atorvastatin and gemcitabine. Well, this increases the risk of myopathy in patients being treated for hyperlipidemia. What is the drug of choice for mastitis? Nafcillin or dicloxoxilin. So mastitis is most commonly caused by Staph aureus, and patients with mastitis present with fever and unilateral breast tenderness. What is the treatment of choice for carcinoid syndrome? Octreotide. What is the treatment of choice for close contacts of meningitis patients? Rifampin or ceftriaxone or ciprofloxacin. So let's say that a patient has meningitis and they were in close contact with a patient that is pregnant. Which of these medications would be appropriate to give that pregnant patient? Leave it in the comment section below. Which antidiabetic drugs can cause weight loss? GLP-1 agonists such as exenatide and DPP-4 inhibitors such as the gliptins. What is the treatment of choice for a UTI in a pregnant patient? Nitrofurantoin or fosfomycin. It's very ideal that you remember that you should not give drugs such as ciprofloxacin because they have teratogenic effects. So no fluoroquinolones for pregnant patients. How do you treat a patient that presents with clinical features of this condition? Basically, you want to take care of your ABCs. So you want to secure the airway, provide IV fluids, and the first line treatment is with atropine. However, if the patient is refractory to atropine or isn't seeing the clinical improvement, then you can go ahead and give glucagon. So for patients with this condition, they present with bradycardia, hypotension, wheezing, hypoglycemia, delirium, seizures, and cardiogenic shock. So typically, IV glucagon is second line if there is profound or refractory hypotension. What is the treatment of choice of otitis externa? Fluoroquinolones. What vaccine should patients who take eculizumab receive? These patients should be vaccinated against Neisseria, and basically you need to remember that eculizumab is a monoclonal antibody against C5. So patients who take this medication or patients with terminal complement deficiency should receive their vaccine against meningitis, specifically for Neisseria, because the complement is needed to basically fight or combat this organism. What is the mechanism of action of vincristine? It inhibits polymerization of microtubules. Another high yield thing that examiners like to test is the adverse side effects of vincristine, and that is it can cause peripheral neuropathy. What is the treatment of choice of otitis media? Amoxicillin and clavulanic acid or cefuroxime. So recall that for otitis externa, it is treated with fluoroquinolones, while for otitis media, it is treated with amoxicillin and clavulanic acid or cefuroxime. This is very high yield, particularly for patients who are not patients, for applicants who are doing the USMLE Step 3. Especially for day 1, you can be heavily tested on antibiotics. If you want to see a higher review on antibiotics, let me know in the comment section below. What class of drugs cause cartilage damage? Fluoroquinolones such as ciprofloxacin and levofloxacin. Administration of sodium nitroprusside can cause the accumulation of what element? Cyanide. So it's very important to look out for, excessive accumulation of cyanide presenting in patients, because, for example, if a patient comes in and they have hypertensive emergency and you administer nitroprusside, you need to be aware of this adverse side effect. Another common cause of cyanide poisoning is a house fire, and these patients usually present with lactic acidosis, altered mental state, and cherry red macula. What vitamin can be used in the treatment of methylglobinemia? High dose ascorbic acid. So basically, to manage this condition, you need to discontinue any medication or drug that could be causing it. And also, you need to give methylene blue. However, it's high yield that you remember that methylene blue is contraindicated in cases such as G6PD deficiency. Basically, methylene blue acts to reduce methemoglobin to hemoglobin, and vitamin C is also a reducing agent. What is the first-line treatment for toxoplasmosis? So to treat this condition, you would need to use these drugs listed here. What is a potential side effect or complication of using fibric acid derivatives and bile acid binding resins? They increase the risk of cholesterol gallstones. What is the best next step in a patient who is in anaphylactic shock and that is unresponsive to their first dose of epinephrine? Give another dose of epinephrine. What are early signs of toxicity with this drug? GI symptoms such as nausea and vomiting, lethargy, respiratory depression, and QT prolongation. What is the treatment of choice of histoplasmosis, blastomycosis, sporotrichosis, and coccidiomycosis? Itraconazole. Which antiretroviral causes vivid dreams? Efavirenz. What is the treatment of choice of entamoeba histolytica? Metronidazole. So recall that patients with entamoeba histolytica can present with bloody diarrhea and liver abscess. Is doxylamine more sedating than desloratadine? Yes. So recall that the second generation antihistamines are less sedating. So I remember these or this concept with the S's. So basically, doxylamine is a first generation H1 blocker, while desloratadine is a second generation H1 blocker. So second generation H1 blockers are less sedating. So how examiners test this concept is, for example, you have an elderly patient and they need to be treated with antihistamine, and they will list drugs and they're all antihistamines. And you have to determine which one is less sedating. Because typically for elderly patients, you want to give them those less sedating drugs. What is the drug of choice for nightmares and PTSD? Prazosin. Prazosin is an alpha blocker that was initially used to treat hypertension, but now it's more commonly used to manage symptoms of BPH and nightmares associated with PTSD. To continue learning more high-yield concepts for the USMLE, just click this video right here.